Hello everyone, welcome to my YouTube channel Medical Hacks. Let's discuss a new topic in medicine, which is COPD, means chronic obstructive lung diseases. Here, first discuss about the definition of the COPD. What is COPD? COPD means the is a disease of the airway which can be preventable and treatable. That is mainly characterized, which consists of the respiratory symptoms and the airflow limitation due to the airway or alveolar abnormality. The abnormality may be in the airway tract or may in the alveoli, mainly which is mainly due to the exposure to the any noxious particle or any gases. The noxious mean the unpleasant particles. Then the COPD includes the two diseases. Mainly one is the chronic bronchitis and another one is emphysema. In some other book, the small airway diseases are also included. At first, the chronic bronchitis. Then let's discuss the definition of the chronic bronchitis according to Davidson. It is defined as the cough and sputum production for at least the 3 months in each two consecutive year. There must be the cough along with the sputum production in 3 months in two consecutive year. That is called the chronic bronchitis, whereas the emphysema is just the enlargement or permanent dilatation of the airway distal to the terminal bronchioles along with the destruction of the wall of the airway. Here, we can discuss some of the extrapulmonary effect of COPD, which include the weight loss and the skeletal muscles dysfunction. About the skeletal muscle dysfunction, we will also discuss later. Here, the one of the major risk factor for COPD is cigarette smoking. Uh, it is unusual to develop the COPD in a patient who has the back year less than 10 years. So, for a patient being for one to become the patient of COPD, the back year for cigarette smoking must be more than 10. Let's discuss the pathophysiology. COPD consists of the both pulmonary and systemic component. Here, when there is airway limitation causes the trapping of the gases and which causes later the hyperinflation of the lungs. And when the lungs is hyperinflated, the pulmonary and the chest wall compliance decreases. What is compliance? Compliance means the stretchability of the lungs, how much it can expand. Here, when the lungs, thus the pulmonary hyperinflations occur, lungs become hyperinflated and filled with the air, which later flatten the diaphragm. When suppose uh, suppose this suppose this is the lungs, and when the lungs become hyperinflated, then it pushes the diaphragm downward to the make it flat, and also it along with it increases the horizontal alignment of the intercostal muscles. When the intercostal muscles are horizontally aligned, then it increases the workload for breathing, which initially increase on exercise, but later when the disease advance, it increases the workload even at the rest. The emphysema can be classified into the centri-oscillatory emphysema, pan-oscillatory emphysema, and paraseptal emphysema. Let's discuss about the clinical feature of COPD. COPD mainly occurs in the patient which is over 40 years of age, and here the COPD can be present with the symptoms of the chronic bronchitis and or breathlessness. Here, depending upon the presentation, the important differential diagnosis of the COPD are such as asthma, which also include the cough and uh, chronic cough and dyspnea, tuberculosis, bronchiectasis, and congestive cardiac failure. These four are the differential diagnosis of COPD. The first and the important symptoms is cough. The cough is also called the smoker coughs because the risk factor was found, most important risk factor was found to be the smoking cigarette. Next, we have also graded the COPD by the MMRC, that is known as the Modified Medical Research Council classification for dyspnea. We will discuss it later. And here in COPD, when the COPD becomes advanced or in the later stages, it may present with the edema and the morning headache. Edema may be seen for the first during the exacerbation, whereas the morning headache seen which is suggestive of the hypercapnia. Due to the decrease in expiration, the CO2 may be retained in the lungs, which causes the morning headache. And let's discuss some of the breath sound finding. The breath sound are typically quiet. We crackles may be accompany the infection, but uh, if persistent, then the COPD can be changed to the bronchiectasis. And in advanced cases of COPD, it may cause the right heart failure, which is also known as the cor pulmonale. And even if in the absence of the right heart failure, the COPD causes the pitting edema due to the salt and water retention from the renal hypoxia and hypercapnia. When the right heart fails, then the heart cannot pump the enough blood. So the due to the less blood to the lung, kidney, the kidney undergo the hypoxia, thus which causes the retention of the salt and water that help in causing of the pitting edema, and this is also known as the core pulmonale. But here it does not have the heart failure, so it is a misnomer in such patient to call the core pulmonale. Later, the patient may develop the fatigue, anorexia, and weight loss, uh, and which may also point to, if weight loss and anorexia and fatigue are present, which may also point to the case of lung cancer. Now the two classical phenotypes of COPD are pink puffer and blue bloater. Pink puffer means emphysema, and blue bloater means chronic bronchitis. Let's discuss some images. And here, this is the pulmonary and systemic feature of COPD. In pulmonary, such as for example in the airways, the mucus secreting gland become enlarged and the goblet cell increases, which thus increases the sputum production and causes leading to the obstruction, which later causes the chronic bronchitis. And in the vessels, for example in the lungs vessels, the vessels undergo the remodeling and impair the cardiac performance. And in the lungs tissue, the lungs tissue loses the elastic tissue, and loss of elastic tissue, inflammation and fibrosis causes the premature closure of the lungs, which causes the gas trapping inside the lung and dynamic hyperinflation, that leading to the change in the pulmonary and chest wall compliance. So the compliance is also directly proportional to the stretchability of the lung tissue. And due to the unopposed action of the protease and oxidase, which causes the destruction of the alveoli, that are the minor smallest part of the lungs, and which may be later manifested as the emphysema. And some of the pulmonary main four thing: mucus hyperproduction, uh, vascular remodeling, in change in the compliance, and destruction of the alveoli, which manifests as emphysema. And for the systemic, there may be the muscular weakness and increase in the cytokines in the blood vessels, whereas the renal undergo the hypoxia and hypercapnia, which causes the salt and water retention. And there may be the altered metabolism in the body that causes the weight loss and BMR. Basal metabolic rate increases that causes the weight loss, and in last, the osteoporosis may be also manifestations. In the patient, they may develop the polycythemia due to the reflex action against the hypoxia, which causes the increase in the erythropoietin from the kidney, which later causes the increase in the blood cells level that manifests as a polycythemia. What are the investigation we can perform? The first investigation, the easiest investigation is the chest X-ray, a radiographic investigation, which is very easy and short time consuming, that can diagnose the cardiac failure, lung cancer, and the presence of the bulla. And also, if the patient may undergo the polycythemia or anemia, we can undergo the blood count investigation, and we can also check the alpha antitrypsin deficiency, which is one of the major cause of the COPD. And later, the spirometry, which is one of the diagnostic criteria. In spirometry, when we use the bronchodilator, the FeB1 by FBC ratio is always less than 70%, but in case of asthma, it increases more than 70% when you use the bronchodilator. That is the main difference between the asthma and COPD. It can be reversed by using the bronchodilator, but the COPD can't be reversed due to the airway trapping in the bullae. When we expire, the bullae are present in the lungs, which causes the airway trapping during expiration. And expiration, the airway trapping causes no change in FEV1 by FBC even after using bronchodilator. And we can also use the measure the lungs volume. For example, when the lungs become hyperinflated, obviously the lungs total capacity will be increased. We can undergo the helium dilution techniques, and we can also go for the body plethysmography. Body plethysmography is this as shown in the figure. And we can also uh, go for the pulse oximetry to check the oxygen saturation is less than 93 or not. In case of the emphysema are present in the minor bronchioles which cannot be seen on the chest x-ray. So we go for the HRCT, high resolution computed topography, which will help to detect, which help in the detection of the emphysema. And for accessing the severity, we there is an criteria. Accessing the severity, there is a criteria. This is the criteria for accessing the severity, and it includes the four stages. Just remember the gold criteria: stage 1, 2, 3, 4. And here the predicted FEB1 by FBC always remain less than 0.7. But when in the stage 1 is the mild stage where the FEB1 is found to be more than 80%, and in stage 2 the FEB1 is found to be from 50 to 70%, and stage 3 the FEB1 is found to be 30 to 49%, and stage 4 the FEB1 is found to be less than 30%. It is the criteria to characterize the severity of the ongoing COPD obstruction or the airflow obstruction in the patient. And we already discussed the as a modified medical research council classification for dyspnea scale. It includes the 5 grading, start from 0 to 4. First, 0 means only dyspnea on the sternal axis, and grade 1 means sternal axis while climbing uphill. Stage 2 means sternal axis wise external exercise while climbing in the ground level with the same age group people. uh, and stage 3 means feeling dyspnea or difficulty in breathing while walking just 100 meters on the ground level. And stage 4 or grade 4 means breathlessness while even undressing and leaving the home. And these are some of the picture finding in this. This zone is the normal lungs. These are the air spaces from the gas exchange can be seen, but this is the infected lungs. Here we can see there are very minute air spaces for the access of the gases, so it's very difficult to access the gases in the case of the COPD patient. This is the lung. So the emphysematous, this is one is the emphysematous lung where the alveoli have been, the airway have been damaged already. And for the management, always first we have to reduce the exposure to the noxious particles. For example, if the person smokes, then avoid or quit the smoking. Then under next step is we can have the pulmonary rehabilitation. Here exercise should be encouraged to all the stages of patient, and we should give the physical training and education and nutritional counseling to the patient. And later, one of the best drug is bronchodilator. Bronchodilator include the short acting bronchodilator, for example the salbutamol. And if nowadays the bronchodilator is also given in combination. If acting bronchodilator are not increases the compliance of the patient, then we can undergo the long acting bronchodilator, for example the formoterol, which comes with combination in the long acting muscarinic receptor antagonist ipratropium bromide. This includes. And if here the oral bronchodilator, for example the theophylline, which is a hypoxanthine group, are only recommended when the long-acting bronchodilator are also not even available in the market. And we can also use the inhaled glucocorticoid and bronchodilator. Here the glucocorticoid means the mainly corticosteroid, which decreases the inflammation. And later the oral anti-inflammatory drug can also be used. Same the glucocorticoid, which may be used in the maintenance, which cannot be used in the maintenance therapy because it causes the osteoporosis and impaired skeletal muscle function. So it is oral glucocorticoid is only recommended while during the exacerbation. And the other maintenance measure is we can give the vaccination. Vaccination are two vaccines mainly for the COPD, that is the pneumococcal vaccine and the annual influenza vaccine. And in case of the severe patient who feel the lower criteria to give the long-term oxygen therapy, that must be incubated with the lungs, that is also known as the long-term domiciliary oxygen therapy, which includes if the PaO2 concentration is less than 55 mmHg, and if PaO2 is from 55 to 60 plus with pulmonary hypertension and the peripheral edema or polycythemia, or patient has stopped the smoking. If at least 2 occasions 3 weeks apart are involved, then we can undergo the long-term oxygen therapy, which is also known as the domiciliary long-term oxygen therapy. And here if medical intervention doesn't work, then we can undergo the surgical intervention. Surgical intervention include the bulectomy, and the long volume reduction surgery, and even in the severe cases we can undergo the lung transplant. And prognosis is inversely related to the age. If the age advanced, then the prognosis is bad, and is also directly related to the post bronchodilatory FEV1 response. And if the person is having undergoing the weight loss and pulmonary hypertension, that is thought to be the bad prognosis for the patient. And here is one index, a BOD index to for check the prognosis, where B stand for the body mass index, O for airflow obstruction, D for dyspnea, and E for exercise capacity. Here, thank you.